Welcome to our second plenary together. My name's Carol Walford. Hello, I'm Chief Clinical Officer at Hospice UK. I've got several announcements to make before we get started with our plenary. The first announcement is regarding Catherine Mannix, who's coming to speak to us tomorrow. And I just wanted to say that she's going to be available for signings of her book tomorrow. And that's going to be in the morning refreshment break and at lunchtime. She's actually speaking at the end of the day. So if you want to buy her book and get it signed, you need to do that before. She won't be around after. The second bit is to say that you get two for the price of one today, because we've got a Hospice UK Lifetime Achievement Award that will be made directly after we've finished this second plenary and we've heard from Lorna Fraser. But before that, I want to introduce Lorna to you. Dr. Lorna Fraser is a senior lecturer in the Department of Health Science at University of York, and she's director of the Martin House Research Unit Centre. She's going to cover the urgent need for high-quality research in paediatric palliative care and how this can underpin development of services and care for those children and families. So, without any further ado, I'd like to introduce you to Lorna.
Thank you very much, Carol, and thank you to Hospice UK for giving me the opportunity to come and speak on the plenary stage about the need for research in children's palliative care. If you'd asked me 5, 6, 7 years ago whether this would happen, I would have said definitely not. I'd like to hold Sarah Russell entirely responsible for my title and reassure you that I'm not going to sing or dance any Elvis songs during this presentation. I have a couple of disclaimers. Carol's already said I'm going to be talking about children here, but I'm also going to be talking about the relationship between children and adults in palliative care and how we can learn from each other, particularly in the research arena. Some of you may feel I'm a little biased as an academic, saying that we need more research, but I'm hoping by the end of this talk that you will also agree with me. So I'm going to give a little bit of a background. I think there are some key differences between children and adults palliative care, and particularly around the hospice sector, that I want to highlight before I go on later to talk about our similarities. Give you some understand why I think we need to do more research. Do a little bit of shameless advertising for my research centre, the Martin House Research Centre, and talk a bit about a research prioritisation exercise that we undertook a year or so ago, before talking really about the way forward and the importance of collaboration. Now, if you're not interested in children and you're not that interested in research, if you go away with the word collaboration in your head, I'll be happy. Okay, so children do still die. More than 5,000 infants, children and adolescents die every year in England and Wales, and with mortality highest in the under ones and the infants. And it's said that they think approximately 50% of these deaths are for children with life-limiting conditions who it may be not an unexpected death and who may benefit from palliative care services. Knowing how the issues we have with recording of diagnoses, etc., on death certificates, I suspect it's higher than 50%. But we also have a large cohort of children and young people who live with complex and life-limiting conditions where their life expectancy may be shortened. This is work we did quite a number of years ago now, but showing that the number and the prevalence of children and young people was increased markedly over this time period, with around 40,000 children in England at that point, and children and young people with a life-limiting condition. This does vary by age group, and for the adult people in the audience, the largest proportional increase over that time period was actually in the 16 to 19-year-olds. We know we're using more aggressive treatments, more medical technologies such as ventilation in these children and young people, so some of them are going to appear in the adult sector's doorstep, and we need to be prepared for that. So apologies for those of you that know this already, but there's more than 60 organisations providing paediatric palliative care in the UK. The vast majority of those are children's hospices. There's more than 50 children's hospices. But there are also 9 hospital specialist-based palliative care teams, as well as numerous community and outreach teams, which either specialise in palliative care or do palliative care as part of their work, along with other community nursing. The children's hospices are interesting. They all have a slightly different model of care. They all look after a slightly different population of children, provide slightly different services. And certainly at this point, I don't think we really know what the most effective and efficient model of providing care to these children is. So I said I was going to highlight a couple of key differences in between the children's sector and the adult sector. So this is the very first piece of work I did 10 years ago now in the children's hospice sector, and we looked at how long children were surviving after they'd been referred to Martin House Children's Hospice. I don't know how many of you are familiar with what we call the ACT, or the Together for Short Lives categories. They're ways of displaying the very broad range of conditions and diagnoses that children and young people with life-limiting conditions have. So category 1, which is the green line there, is children with cancer or children with organ failure, where there may potentially be a curative option, but that may fail. The second category are children with relapsing and remitting diseases such as cystic fibrosis, but where ultimately they will have a shortened life expectancy. Category 3 is the progressive conditions, a lot of neuromuscular and neurodegenerative conditions. And category 4 is what we call static conditions, but still where the child is at risk of early death, such as severe cerebral palsy. Now, I've just been in the previous presentation, somebody stood up and asked a question and said that the average length of time that people were cared for by their hospice was 14 days. Now, there isn't a typo in the bottom on the x-axis here. This is years. So you can see, apart from category 1, for categories 2, 3 and 4, a quarter of the children and young people were still being cared for 10 years after they'd been referred to the hospice. And actually for all categories, there was a few children around who'd been cared for almost 20 years. It's a very different model of care. The other thing that's different between children and adult hospices is the type of care that they provide. So again, this is quite an old study now, but we looked at hospice provision and usage amongst children and young people with neuromuscular disease in the UK. And they accounted for between 5 and 35% of the population cared for by the hospices, so one of the larger groups cared for by children's hospices at that time. But nearly 3/4 of the visits to children's hospice in this population were for planned or respite stays, not for end of life. The age at which these children, these young people left the hospice varied between 18 and 35, and this survey identified that most patients who were discharged were not being offered an equivalent adult service. So why do we need research? I hope it's more than just keeping me in a job, or as my mum would say, I'd have to get a proper job. All health care is now evidence-based, and I'm not sure why we should be any different in the children's palliative care world. I think there is opportunities to use research to help improve care and outcomes for children and the families. And I think we mustn't forget the potential to harm. Even well-meaning interventions still have the potential to harm. And if we don't fully understand the outcomes from interventions, we can't be sure that they are free from harm. The other issue is about targeting finite resources. I think every second conversation I've overheard today has been people talking about resources and money and funding. And it's always been a big issue for the hospice sector, but it's becoming an even bigger one at present. So we need to be sure that we're targeting our finite resources where they can be most effective. Now, research in children's palliative care is not new. There's papers in the late 60s, early 70s about the dying child. The first paper I could find about hospice care in children was from Helen House. So Helen House was, for those of you who don't know, the first children's hospice in the world when it opened towards the end of 1982. This was a paper in the BMJ, so the BMJ ahead of having children's palliative care published in the mid-80s. But what I was very interested in, so this was a review of the patients that they'd looked after in the first year of Helen House. And those of you that are working in children's palliative care at the moment will recognise most of these conditions and most of these diagnoses, because bar in the bottom right-hand corner, we've got cystic fibrosis, which is a condition that's rarely seen in children's hospices now. All the other conditions, such as mucopolysaccharidosis and the other congenital conditions, are still seen by the hospices. But what was also very interesting to me in this paper was the model of care. And you can see even in the first year, there was only a very small minority of these young people who were there for end-of-life care. The rest of them were there for these planned stays for progressive disease, or as they called it at the time, severe handicap. So we have been doing research in children's palliative care for quite a long time. NICE guidelines, again, those who work in the sector know that we had NICE guidelines for the end-of-life care for children and young people published almost 2 years ago now, which is fantastic. And these have been great, particularly at getting acute NHS organisations to sit up and think about what they're offering and how they're resourcing end-of-life care for children and young people. But what it also did was draw attention to a large number of gaps of research in this area. There's 143 recommendations in this document. I'm not sure if that's a record for NICE guidelines, but it must be up there. But many of these have had to be made on low or very low quality evidence, and therefore based on expert opinion rather than an evidence base. Now, myself and my colleagues won't have been doing our job properly if in 5 years' time, when we're revising these guidelines, there isn't some more better quality evidence on which some of these recommendations can be made. Okay, so here's my shameless advertising for the Martin House Research Centre. It's also an example of a great partnership between a voluntary sector organisation and an academic organisation. So the history of Martin House. So Martin House was the second children's hospice in the UK when it opened its doors in 1987. So it was 31 years old this year. These three people were very instrumental in research in Martin House. So Mike Miller, who was a consultant in paediatric palliative care, and Jan Aldridge, along with Patricia McKinney, my old professor of paediatric epidemiology at University of Leeds. Now, I forgot when I put these slides up that Mike, of course, Hospice UK is now, should be very thankful that they have Mike as one of their board of trustees, providing the children's voice. But Martin has been involved in research for many years and funded research since I became involved in the sector in 2007. And the trustees were very supportive of research, very keen to be a research active hospice. And when we took a very, what I thought was an ambitious proposal to them about 3 years ago to develop, for a much larger investment and to develop a research centre, I was very pleased when the trustees supported that decision. And we now have the Martin House Research Centre, which is a partnership between the two organisations. It is a multidisciplinary centre for research on the care and support of both the children and young people with life-limiting conditions, their families, but also in the palliative care workforce. We're holistic in scope. Children and young people don't live only in the healthcare system, they also live in education. These families also have social parenting, financial needs as well. The main aim is to undertake high-quality research, which should have national and international importance, and the output should be the evidence which will help ensure that children and families receive equitable, high-quality care when they need it and where they need it. So I can't believe we're actually coming towards the end of our second year as a research centre, and I put this slide up to show the importance of young people and families in what we do, and they're heavily involved in the work of the research centre. We're also very aware that just undertaking research studies itself absolutely answers some of the questions that we might have, but we also need to capacity build, we also need to work with the sector, we need to work with other academic colleagues. So we have several PhD students. I work closely with the Yorkshire and Humber Children's Palliative Care Network. I'm trying to do Twitter, I'm not very good at it. I retweet most of the time, but trying to get the relationship between academia and the sector growing and get the capacity and understanding of research in this field. If you're interested more in what we're doing, we do have a website listing all of our projects and our governance arrangements, etc. So when we launched the centre, and we knew the NICE guidelines had been published a couple of months before, but we were aware there were so many questions that we could be answering. And should I just go and do what I'm interested in? I like counting things. Should I just go and do studies about the epidemiology of children and young people? What was really important? How should we be spending these very important money that's been invested and entrusted in the research centre? And we're also very aware that there have been quite a few research prioritisation exercises done in this field and in related fields. So we decided to undertake a systematic review of these, and if you're interested, it was published in Palliative Medicine last month, but also to consult with key stakeholders. So in our review, we found 24 studies, which encompassed 279 research priorities. They were framed in very different ways. How to do a research prioritisation exercise is not really, there are many ways you can do it, and there's many ways you can report on it. So actually gathering these together, and that's them all listed in that table there. If you are interested in supplement to the journal, has listed every single one of them. But some of them are framed in specific questions, like does melatonin improve sleep with children with neurological conditions, where other ones were simply one-word topic areas such as pain or sleep. But what was really noticeable to us was very little input from parents or young people in these prioritisation exercises, or indeed where they had attempted to, they had very few involved. And the majority of these were priorities that have been given by healthcare professionals. Now, those in their own right are very important, but we also need to understand what's important to the children, young people and their parents. So we tried to take these nearly 280 questions and put them in some sort of categorisation that we could actually use and manage. And it was such a rich source of data that we actually did a summary booklet and sent to our key stakeholders that were going to come to our consultation event a couple of weeks beforehand, so they had time to really understand and get embroiled in these data. We had a very successful consultation event. We had more than 40 individuals invited and turn up. Yes, we had academics and healthcare professionals, but we also had parents, we had chaplain, we had young people, as well as charity representatives and organisational representatives. And we worked in groups. It was a fantastic day, apart from that I got to facilitate the group with the medical consultants, and they never like to do what they're told. They never play by the rules. So what we got them to do was, first of all, because they'd read this booklet that summarised all these different priorities, we also asked them if there was any burning questions that they had that they felt weren't covered anywhere, could they write them on a sticky note and put them on our board. So we did that. And then we did Q-sort boards. I don't know if you're familiar with those, but it's a triangle. And we asked the groups to prioritise on the right-hand side topic areas that we should be focusing on the left-hand side, the ones that were of least interest. And you can see, I think the purple board in the middle was the doctors. They've got about 5 of the most highest priority. They wouldn't play by the rules. We also, interestingly, asked them to take any topics that they think we shouldn't be interested in and put them at the top if there was things that they felt were adequately covered by other research centres or other people working in this area. So what did we come up with? So we came up with 12 topic areas, and I'm going to go through them in turn, but the usual suspects of communication, decision-making, care and support needs. Those of you that know me will not be surprised to see there's some epidemiology and population questions in there. Bereavement support came up as a very big topic, as is emotional and psychological issues. It's probably the topic with the most sub-questions under it. Some questions about workforce, and interestingly, the young people were very interested in the care of the workforce as well as the care of their parents. Service delivery models of care, huge questions about how we do that, as well as some more interventions about more medical interventions such as symptom management. We had one new topic that arose from our stakeholder day, which was about the spiritual needs and cares, which was something that hadn't appeared anywhere in the published literature. But I was very interested in, I think to me this highlights the value of having young people and parents at events. So the parents had 4 burning questions that they didn't really feel were covered in the other topics. The first 2 were about psychological and emotional needs, particularly for the whole, for the full family, but B, also when the disease trajectory and the outcome was not known and it was uncertain, and they weren't really sure what was going to be happening to their child. And the second 2 questions were about transitioning to adult services, and why is it so difficult, and why are the services just not there, and why do people not plan? Again, these will not be surprising to many of you in the audience. The young people, I said they were interested in workforce, but their top question was actually about pre- and post-bereavement support, with a real emphasis on spiritual and religious support. And this is something that hadn't come up previously, and we wouldn't have been aware of, and are actually taking forward in a grant application at the moment. Again, the professionals had different priorities. They were particularly interested in how involved the children and young people were in decisions around their care. And they had a kind of catch-all other question, was essentially how should their services be designed for when, and how has this changed, which is probably about 10 questions in one. So what did we do with this? So the green boxes are studies that we have underway at the moment in these topic areas. We aren't ignoring the other ones. We're very aware that the decision-making communication is a big topic for the Louis Dundas Centre in London. And also the bottom left-hand side there, the measurement and outcomes. It's fantastic that Richard Harding from Cicely Saunders has just started a programme of work about child outcome scales in palliative care, which is something we very much need. So in terms of the epidemiology and population, that table I showed you in my second slide in about the numbers of children and young people with life-limiting conditions, and therefore would have palliative care needs. We're trying to update that at the moment. But what we're trying to do is A, refine our estimates, but B, as service providers, you're not really that interested in how many children there was 10 years ago. You want to know how many children there are in 5, 10, 15 years' time. So we're trying to project forward. It is challenging, though. Martin House and St Leonard's have one of the Together for Short Lives funded studies about transition, and we're evaluating how successful the Young Adult Project has been and what we can learn from that. I said bereavement was a big topic. We're just coming to the end of a systematic review, and I find it quite shocking. Over 40 years, there's been 7 published studies of bereavement interventions solely for parents, and there is really no evidence of effectiveness. The Early Days project on use of cold bedrooms and materials. If you're interested in that, there's a poster 75 downstairs if you want to know more about that study. I said emotional and psychological issues were very important. We have 2 PhD students working on anxiety and depression in children with life-limiting conditions, and also looking, the second one, at psychosocial support for siblings and that impact on practice. And I myself am starting a study in the new year looking at both the psychological and physical health of mothers of children with a life-limited condition. We have huge expectations on these mothers, both to be parents but also to be carers of these children. Workforce is important. I'm going to come on later and talk about how the sector can be involved, but we're starting a study in the new year looking at staff support interventions and practices in children's hospice. We've heard already about issues of retention, issues of being unable to keep staff and high vacancy rates. I think the service delivery models of care is a real big issue, but one of the challenges until we have good outcome measures is really how you can make comparisons between different models. We are doing some pieces of work looking at the role of specialist paediatric palliative care in children with oncology diagnoses, the impact of GP involvement on patterns of unplanned healthcare use in these children and young people. And one of my fellows is starting another MHRC study looking at changes in unplanned healthcare and costs during and after the transition to adult care, and to see if this cliff edge that we talk about really exists within these data. And lastly, sorry, this is a little bit dull, just listening through studies. But last one, in terms of health interventions, we have 2 studies. One about the role of different diets, so particularly around the role of blended diets in children who are gastrostomy fed, but also the issue of polypharmacy, and particularly problematic polypharmacy in children with life-limiting conditions. But there are still lots and lots of questions that need answered. I've given you about 12 titles of projects there. There was 279 priorities. So there's lots more to do. So how do we take this forward as a sector? I think we need to be using robust methodology. I think we need to think about the scale of studies. Every time I come to a conference, I see some fantastic work being done by individual organisations, and I just wonder, why do we not group together? Why do we not combine this knowledge? I think I'm going to talk a little bit about shared learning, and the last thing about asking the right questions. But in order to do all of this, we need to be developing and sustaining collaboration, both within organisations in the sector, but also with academics and other key stakeholders. It can be done in Canada. I don't particularly like their acronym, but they have a network for accessible, sustainable and collaborative research in paediatric palliative care that's been going for about 10 or 11 years now. Hal Seiden on the left there is a medical director at Cannock Place Children's Hospice in Vancouver and is the lead for this project. I particularly like their support team. Unfortunately, Poppy the dog did die last month, but hopefully they will have, I'm sure she'll receive very good care. But hopefully they will replace her. So robust methodology. I know we work with a vulnerable population, but please can we stop using that as an excuse for doing things not as well as we could. There are people in science who believe that randomised controlled trials and meta-analysis are the only way to answer a question in a robust method. I'm afraid I don't agree with that, and I really think that I think A very well-designed qualitative study can be in the blue area, and a poor randomised controlled trial can equally be in the red area. But I do think we need to be thinking about the scale of studies. This is a relatively large population in terms of children, but still a small population for doing any trials and other studies. So we do need to be working together, whether that's nationally or internationally, where appropriate, to be answering the key questions. And I would make a plea to partner with academics. We have the time to think about these things, but we equally need you as service providers and clinicians. So I'm going to talk about shared learning. If I had £1 for every time I was told that paediatric palliative care is special and we can't do things like other people do, I'd be a very rich person and not standing here. I'd have a camper van and I'd be happily away with my dog walking around the hills of Scotland. But I haven't. And I think there are ways. I think we do need to think about the large overlaps we have with other specialties. Paediatric neurology, paediatric intensive care, paediatric oncology, neurodisability are big paediatric specialties. There's huge crossover between our patient population. But I also think there's a large crossover and some shared learning between adult and paediatric palliative care. So I was interested to find this paper from the Royal Society of Medicine from 1969, when there was a meeting about the management of fatal illness in childhood. And even I can't do a presentation about research in palliative care and not mention Cicely Saunders. And she was at that meeting, and I think it was very poignant what she said. So it's never wise to speak from anything other than one's own experience, and I have to admit that I rarely do care for children with a terminal illness. However, I've been looking after those who are dying all other ages, and whenever I have discussed our problems, I've found them remarkably similar. So she's acknowledging at that point, yes, there are differences, but there are also key areas where we can learn from each other. We heard earlier from Tracy some of the changes in the diagnoses of the people being looked at, the adults being looked after by adult palliative care, grappling with issues around multimorbidity and parallel planning, things that paediatric services have been dealing with for many years. So you can learn from us. But equally, we can learn from you. You have such a long history in research with Cicely Saunders and colleagues. And we also should have the shared population of interest in this population of children who are outgrowing paediatric services but still have very high healthcare needs and reduced life expectancy, that the children's palliative care should be one component of their healthcare when they become young adults. And I'm really pleased to see that Together for Short Lives have just announced another 8 collaborative projects in their Improving Transitions for Young People Fund. There's projects in there partnering with Royal College of GPs, with some of the adult hospices, various different organisations. But from my point of view, they've also inbuilt evaluation. And we do so many changes in the services, changing service design and models without thinking about evaluation. And it's so important we understand, has something worked? And if not, why not? Or how we could make this better if we did it again. I said we could learn a lot from other paediatric specialties. I always choose ICU because they have nice data. So there's a national database of all children that are admitted to intensive care. And when I looked at this a couple of years ago, and it's a large cohort from about 12 years worth of data, so 150,000 children who'd been in intensive care. Children with a life-limiting condition accounted for nearly 58% of all these admissions, 72% of all bed days, 87.5% of all admissions that lasted longer than 4 weeks, nearly 3/4 of all ICU deaths, and these children were also 2.5 times more likely to die in the year after discharge. So we have such a shared population here that we should be learning, and a lot of research is undertaken in the PICU setting. Again, staying in PICU, before you start throwing tomatoes at me about place, because I mentioned place of death, I do not believe that on an individual basis we should make assumptions about where people want to die, and that includes children and young people. But I do think if we're looking at population level and we're managing to offer choice, we should see some distribution between the places of death that are offered. So again, this is a slightly shorter time period on the same data set, about 110,000 children who were discharged alive from intensive care, and just over 7,700 of them had died after that first discharge. You can see, I don't know how well this projects, but the blue line is hospital deaths and the orange one is PICU deaths, and you can see there's a gradual reduction over that time period, and an associated increase in the yellow line, which is home, and the grey line, which is hospice. So in hospice, deaths have gone from 4% to 12% over that 11-year time period. What was key for me in this analysis, however, was that children, at the point of, if they'd ever been discharged to palliative care at the point of discharge, if they died, were 8 times more likely to die out of hospital. So something about palliative care being able to offer choice here. So asking the right question. I'm quite a simple person, and I think there's lots of interesting questions we could ask, but if we can't answer the so what question, then should we be doing it? We have as finite resources in research as we do in clinical practice. So if the question that you're going to answer isn't going to, if you can't articulate what difference this research will make to the lives of children or with life-limiting conditions or their families, or how does this advance the science in this field, then I would argue that we shouldn't be using these resources to answer that question. I think key partnerships are very important. This isn't about me sitting in my academic ivory tower, which is really a large 1970s concrete block, albeit in York. But I think, clinicians, parents, children, young people, service providers, policymakers, and the third sector organisations are all very important. You need everybody around the table talking about research, both in terms of identifying the questions and undertaking research, but particularly around dissemination. I can't stress how important the parents and young people are to what we do. This is our, what we were calling our PPPI, and our parents told us we should call it FAB, our Family Advisory Board. Unfortunately, I always think of that terrible ice cream with sprinkles on top of chocolate. But I need to get away from that. But they've been instrumental and have challenged us at every point, particularly around how we undertake research. And a key message from them, for those of you in the audience, are they're the ones that want to say no if they're being asked to do something. They don't want people saying no on their behalf. Sector involvement is very important. They're involved strongly in our research prioritisation exercise. We also have clinical members of all our project steering groups, as well as voluntary sector members. Recruitment of children and families is very important, and not acting as a facilitator and not acting as a gatekeeper where appropriate. We will want some of you guys to participate in our research studies. We talked about the staff support study earlier. But the big area where you can help us is dissemination. I'm not here, my university can't hear me, I'm not that interested in academic publications. I'm interested in undertaking research that's effectively disseminated and implemented, and therefore makes a difference to the lives of children and families, and also the workforce. So we need to get better at how we disseminate research. And working together at the point, particularly around the point of sharing and being able to measure the impact, what's changed because of what we have found or what we have done. It's not without its challenges. I'm quite often seen trying to tear my hair out, very occasionally seen doing this, and it's not uncommon for me to say I'm going off to be a dog walker, because that would be my preferred profession, and I thoroughly enjoyed helping Molly Dog earlier. But the rewards are, rewards are phenomenal. Seeing the engagement of the young people and the parents and what we're doing, and hopefully making a difference to the lives of these children and families is priceless, really. So I hope you agree that I've given you some evidence on which to base the statement that there's still a need for high-quality research in paediatric palliative care. Yes, there's increasing numbers of studies underway from both the research centre I work in and other places across the UK, but collaboration is key to success. And to echo what Tracy said earlier, I do think together we can do this. Thank you.
Time to ask some questions from Lorna. I just wondered whether there are any questions from the floor. We've got 2 people with roving mics. We've got one at the front here with Tracy. We'll start there.
Hi, Tracy Bleakley, Chief Exec of Hospice UK. Thank you, Lorna. That was absolutely fascinating. My question is about putting research into practice, because you talked about wanting to make impact with your work. So first of all, the last thing we want to do is put the not so good research into practice that you identified. So how do we recognise it? How do we recognise the good stuff? And then can you give us any hints and tips on how to translate good research into change and practice?
Nice short questions, thanks Tracy. I think, I mean, we could do a whole session on how to appraise research, but I think if you can't, when you hear somebody talk or you read a paper, if you can't fully understand what's been done and why it's been done, then I would question whether that was robust enough to be making any assumptions, making any changes to what you were doing. Jamila Hussain did a wonderful presentation earlier talking about missing data and making sure that the population that these research has been done is actually relevant to the population that you're wanting to use it in, and I think that's very important as well, and ensuring what people mean by their terminology and definitions is the same. I think getting implementing in knowledge translation is it's difficult, but we need to get better at it, and we only get better at it by working with organisations such as yourselves, but also organisations on the ground, organisations providing care to children and young people. And I think we've been very aware of that and have therefore involved these organisations in all of our studies. So they feel that the last thing we want to be doing is coming along and just presenting a final report or a paper and saying, look, what do you think, help us put this into practice, when they haven't fully been able to understand what we've done and why we've done it.
Also, is there anywhere that adult hospices should go to find out more about transitions research if they're new to the area?
There are a few, or actually quite a number of papers that have been looking at issues of transition, and I always think they often highlight the problems and not often the solutions. So I'm hoping that the work that I would advise going to Together for Short Lives website, there's now 10 or 11 projects in the transition funds that have been funded looking at what they're doing. It will be a wee while before we have the results of some of those, but learning from and speaking to those people I think would be
brilliant. Thank you.
We just thank Lorna again, and then I'd like to ask